So here you are watching base tongue reduction in a case of 42-year-old male with a BMI of 27 and AHI of 69. He's got retrognathia, so his tongue is placed a little backward. We have performed his yellow palatopharyngoplasty with suspension wig already. Now you can see that his base tongue is not large. It's only placed behind. This is the foramen cecum, and it's only this area, the higher part of the base tongue, which is actually placed a little behind. So you can see the epiglottis. I'm not going to do anything to the area below because that area is not contributing to the collapse. I'm only shrinking this area. So obviously there is no throat pack here. Can you give me a patty, sister? I will keep a small patty only to make sure that the saline does not go inside. But if I keep a throat pack, then it's not allowing me to perform the surgery. So I'll put a small patty over there only to protect the saline from directly going inside, though the tube is inflated. I'll simply put a patty over there, and I will only coagulate. I'm not ablating anything. I'm only coagulating the tongue base, and you will see only with coagulation around 4 to 5 millimeter reduction will happen. At least 3 to 4 millimeter will surely happen, and only with coagulation. So there's no question of ablation, bleeding, and all. I'm coagulating with ablation at a setting of 3. Sorry, it's a setting of 4. Ablation, coagulation is at the setting of 4, and only with coagulation you can see the lymphoid tissue is completely flattened. This is the muscle, and there will be some reduction of the muscle as well. That's the epiglottis. You can see the epiglottis is completely curled on itself. And I'm passing some energy by coagulation at a setting of 4 for coagulation. There's no ablation happening. That's the midline. So I'll go now across the midline. Right side is done. It's a small procedure, but will go a long way in controlling the sleep apnea of this patient. Now you can see this tube is taken from the left nostril, so it's coming in the on the left hand side. So if I have to bring the tube on the right side, I'll ask the assistant to move the. Now this is a new technique. We have not used that before. So if you move the larynx from outside, so can you push it here? Yeah. So if you push the larynx from outside, you can see the tube moving from inside. So can you push it? Yeah. Keep it pushed. What I'll do is I'll only coagulate the tissues, so there'll be no ablation. A little bit of lymphoid tissue and a lot of energy into the muscles. Though it is only a surface coagulation, but at a setting of 4, you can see a lot of thermal energy is going, a lot of coagulation energy is actually going inside the muscles also, and this will tighten the tongue base so that the collapse will reduce. Since there was no collapse of the epiglottis seen on the during the sleep endoscopy, I need not damage the mucosa on the epiglottis. It was only the upper part of the tongue base which was actually collapsing. So I'm coagulating only the upper part of the tongue base here. I've not gone, in this case, leave it. I've not gone till the median glossoepiglottic ligament. I've not gone till the lateral glossoepiglottic ligament, which I do for the lower tongue base. So this is a very safe technique for partially reducing the upper tongue base, and will extubate this patient on table right away. I'm just passing a little more energy so that this tongue base can fibrose as much as possible without any bleeding. And since, as I said, since there is no epiglottic collapse, so I'm not doing anything to the epiglottis. The fatty is now getting removed, and that's the reduction of the tongue base. The higher tongue base, I can possibly reduce a little bit more on this side, and the lymphoid tissue here, and pass some more energy into the musculature of the tongue. So this is a very, very simple technique. No risk of uh, aggressive bleeding because we have not ablated anything. We only coagulated the coagulation at a setting of 4 for coagulation. So thank you for watching.